Hello, so today we'll be talking about the influence of a clinical lifestyle-based weight loss program on the metabolic risk profile of metabolically normal and abnormal obese adults. So this is my article that I reviewed. So this kind of the main overview and purpose of this study was just to investigate whether the gold standard treatment for obesity, that 5 to 10% weight loss, would be as beneficial for metabolically normal obese adults. So I'll be talking about the background, the objective, study population, study design, results, strengths and limitations, and the conclusions and next steps. So some background on this topic. So there's a subgroup of obese individuals who are metabolically normal. So that means they have normal blood pressure, high levels of insulin sensitivity, normal blood glucose, favorable lipid profile. So the standard treatment for obese individuals with comorbidities is weight loss, that 5 to 10% reduction in initial body weight. But it's controversial whether weight loss can help metabolically normal obese and overweight individuals to the same extent that it helps those that are metabolically abnormal. There was one study done that actually showed that metabolically normal obese adults with a 10% weight loss actually had a decrease in insulin sensitivity. So there had been several different studies done prior to this one that had kind of shown conflicting results. And so this study wanted to investigate a large sample size and explore the prescription of a 5 to 10% weight loss for overweight and obese individuals without metabolic risk factors to see if some of these conflicting conclusions could be kind of figured out a little bit more. So for this study, the definition of metabolically abnormal overweight or obese individuals, they had to fulfill one or more risk factors. So they had to either have a fasting plasma glucose greater or equal to 7.0 millimoles per liter, or a doctor diagnosed type 2 diabetes, or they had to be taking medications to treat high fasting plasma glucose. They had to have triglycerides greater than 2.26 millimole per liter, or doctor diagnosed hyperlipidemia, or they had to be taking medications to treat their high triglycerides. They had to have a systolic blood pressure greater than or equal to 140, diastolic blood pressure greater than or equal to 90, or doctor diagnosed hypertension or a medication to treat hypertension. HDL less than 1.04 millimole per liter, LDL-C greater than or equal to 4.14 millimole per liter. So if they, for this study, if they fulfilled one or more of these risk factors, they were considered metabolically abnormal for this study. So the purpose of this study was to examine the impact of weight loss on the cardiometabolic risk profile among metabolically normal and abnormal overweight and obese individuals. So the study population, there was 392 overweight and obese adults. They were between the ages of 18 to 88 years old. There was 332 females and 60 males. And they were all recruited from the Wharton Medical Clinic. So this is a referral-based clinic that specializes in weight management. It's based in Canada. Those who had bariatric surgery were less than 18, had a BMI less than 25, had attended the clinic for less than 3 months or less than 3 visits, had missing BMI or missing metabolic parameters, or had extreme values of weight change were excluded. So the study design. So this was a cohort study, and so there was, at an initial visit, they had their baseline blood pressure, height, body weight, medical history taken, and they attended a workshop on weight management that was led by bariatric RDs. So they talked about different lifestyle changes they could make to lose weight. They talked about meal planning. They talked about aerobic exercise. And then patients also had an exam by a doctor. At the second visit, they were given a calorie-restricted meal plan that was administered, and they came up with this meal plan by calculating the RMR through indirect calorimetry. Patients were either given a 500 or 1,000 calorie restricted diet, depending on their BMI and other factors. And then they also attended a second workshop that would talk more about meal planning, strategies for weight loss, and different aerobic exercises that they could do. Between their first and the third visit, they had they underwent blood work, cardiac testing, and different exercise stress testing. And then their MD reviewed their diagnostic test results to determine if other testing was needed. They also used this testing to determine whether patients were metabolically normal or abnormal for the purpose of this study. And then the MD also wanted to review whether there were other issues contributing to their weight, and that would maybe be problems for them to lose weight. At subsequent visits, they had their blood pressure taken and their body weight measured. They attended more lifestyle intervention-related workshops. Their weight loss progress was looked at, and their adherence to their prescribed meal plan was also looked at. On average, patients attended the clinic for 13.8 months and made about 15 visits. So this study defined metabolically abnormal as having to meet these clinical cutoffs. And so at baseline, 21.8% of the population had zero risk factors. And then at follow-up, 53.6% had zero risk factors. So this graph on the side just kind of depicts how at the conclusion of this, there was a greater population that had no risk factors at the end of this. Now, if they had used subclinical cutoffs, there would have been a much smaller percentage of people that could have been categorized as metabolically normal at baseline. They would have only had 3.6% of the population as zero risk factors, and at follow-up, only 11.2%. So that's why it really matters what you use to define this metabolically normal obesity, because as you can see, the white is using the clinical cutoffs, and then the black is using the subclinical cutoffs. So it's a much smaller percentage of people if you use subclinical cutoffs that are actually metabolically normal. Metabolically normal obese patients who did have a 5% weight loss were younger, they weighed less at baseline, they had a smaller waist circumference, and they attended the clinic for a shorter duration compared to metabolically abnormal patients. So there's a thought that metabolically normal obese adults have a higher risk of developing future risk factors, so future hypertension than those that are metabolically normal and at a normal weight. So this kind of shows that possibly those that didn't achieve that 5% weight loss and were still metabolically normal might just be younger, they might weigh a little less. So kind of looking at that theory that they're more likely to develop risk factors in the future. 41.5% of metabolically normal obese adults did attain a 5% weight loss in this study. Some more results. So patients who attained a 5% weight loss were 35% less likely to develop an additional metabolic factor at follow-up. Metabolically normal obese patients with 5% weight loss had significantly greater improvements in their triglycerides, their HDL, compared to metabolically normal obese adults who did not have the 5% weight loss. And then the metabolically abnormal obese patients with a 5% weight loss had significant improvements in fasting plasma glucose, triglycerides, systolic BP, diastolic BP, and HDL relative to metabolically abnormal obese patients who did not lose weight. So that kind of just points to the fact that that gold standard of weight loss still holds true, even in this study. So some strengths and limitations of this study. Some limitations was it's a cohort study, so it's not going to hold the same strength that a randomized control study would hold. There was no data on ethnicity and socioeconomic status, so there's no information on how generalizable to the general population this would be. There were a much higher percentage of women in this sample compared to men. And there was no data collected on the specific diet and exercise regimen of the patients. So although they were given meal plans to follow, we don't know what types of foods they were eating. We don't know what exercise they were completing. We don't know whether their diet, included more whole grains and and fruits and vegetables, or if their diet was less calories, but it was all just chips. So there's no information on what they actually ate. We just know that they ate a certain number of calories every day that they were assigned. Some strengths, though, it's a large sample size. So up to this point, it had been the largest sample of this type of study conducted. Patients were provided with education on lifestyle modifications. So they were given meal planning strategies. They were given ways to maintain that weight loss. They were talked to by a doctor, and they attended this clinic for many, many months. And that helped them be able to sustain this weight loss, hopefully. The patients were provided with individual daily calorie needs based on RMR calculated using indirect calorimetry. So they were all given indirect calorie goals, and they met with an RD in order to create strategies that they could use to meet those calorie goals. But again, we just don't know what they actually ate. We can assume that because they were meeting with an RD, they were likely given strategies on eating, more whole grains, more fruits, more vegetables, but we don't actually know what they ate. So some conclusions and next steps. So they concluded lifestyle modifications are beneficial for improving metabolic risk, even if the amount is not the clinically significant 5%. So no matter any amount of weight that was lost did improve their metabolic risk parameters, no matter if it was 1%, 2%, or the 5%. But they also pointed out that you need to look at the benefits of weight loss against the negative effects of repeated failed weight loss maintenance. So it is really, there's a high percentage of people that a year after they lose the weight, they've regained their weight back. We need to look at whether that yo-yoing of gaining weight, losing weight, gaining weight, losing weight is worse clinically for patients over being overweight or obese, but having a maintained and steady weight. So looking at the benefits and risks of weight loss. Another thing that would be helpful for the future studies would be creating a uniform definition for metabolically normal obese individuals. So like I was saying earlier, that cutoff that people can use to have to be metabolically normal is different in every study. And that's really hard to compare because some studies can say there's as small as maybe 3% of the people had zero risk factors and were metabolically normal. But this study, because they used clinical cutoffs, had a much higher percentage of people that had zero risk factors at the start. They had 21%. Also need to use a randomized control study to strengthen these conclusions. That's the gold standard, and this study, again, was just a cohort study, and so being able to find a randomized control study or conduct a randomized control study and that found the same conclusions would make this have a lot stronger, make it look like a lot stronger results. And these are some of my references. Thanks for listening.